Welcome to the Deep Dive, the place where we really try to break down complex stuff and make it useful for you. Today we're tackling something super important and pretty specialized, the whole world of pediatric assessment. If most of what you know comes from adult medicine, well, assessing a child is. It's a whole different ballgame. You really need a reset on how you approach things, the order you do them in, even the basic knowledge.
Absolutely. And it's so important, for you listening to get this right away. We're not just talking about small adults here. Their physiology, how their bodies work, it's fundamentally different.
No.
So the stuff we've pulled together today, it really hammers home that pediatric care needs a different approach, a different sequence, a whole different knowledge base.
And our goal here is to give you that shortcut.
Right.
To help you understand those key differences, the unique anatomy, those crucial developmental milestones, the right processes, so you don't feel overwhelmed by all the details.
Yeah, we want to synthesize the clinical essentials, give you those aha moments where you see exactly how different pediatric practice is from the adult world.
So you feel really equipped, with that critical knowledge for understanding how infants and children are doing health-wise.
And knowing this stuff matters immediately in a clinical setting. I mean, a child's body handles illness, injury, even metabolic stress in ways that are just unique. If you miss those age-specific details, well, the consequences can be pretty significant. So we really need to start with that physiological foundation.
Okay, let's unpack some of those anatomical differences first, the ones that really set pediatric care apart. When you look at their basic structure, one thing that really jumps out is how flexible a child's body is, like their skeleton. The sources point out their bones aren't fully hardened, not fully calcified yet. They're more flexible, more like cartilage compared to adult bones.
Right, and that flexibility is why you see those green stick fractures so often in kids.
Oh.
The bone sort of bends and cracks on one side, but it doesn't snap clean through like an adult bone might. And the sheath around the bone, the periosteum, it's much thicker and stronger too. That actually helps them heal incredibly fast.
Interesting. So while the long bones are flexible, you mentioned something about the upper body, the airway, having some surprising rigidity.
Especially in babies.
Yeah, exactly. And this leads to that really crucial point about the tongue and the mouth. Up until about 6 months old, give or take, an infant's tongue is actually pretty large compared to the size of their mouth.
Okay, and what's the direct result of that? What does that mean clinically?
It means they have to breathe through their nose. Physiologically, they're obligate nose breathers.
Wow, okay. That's huge.
It is, because if those nasal passages get blocked, from a simple cold, some mucus, that infant can get into respiratory distress much, much faster than an older child or an adult. They can't just switch to breathing through their mouth easily.
Right.
So their inability to compensate quickly makes checking the nose, making sure it's clear, maybe even suctioning an immediate priority. That really changes your whole initial assessment, especially in an urgent situation.
Yeah.
Okay, so moving from anatomy to physiology, what about findings that might seem alarming in an adult but are actually normal or expected in a child?
This is where knowing the age group is just like everything. The sources highlight that, certain heart murmurs and something called the S3 heart sound can be totally normal findings, not necessarily a sign of disease.
Okay, tell us more about that S3 sound.
Sure. So the S3, it's a third heart sound, and it's often caused by the blood rushing into the ventricles really quickly during filling. In kids, partly because they have higher cardiac output and their chest walls are thinner, you can sometimes hear the sound, and it's completely fine, benign.
A physiological S3, right?
Exactly. And similarly, a lot of murmurs in children are what we call innocent or flow murmurs. Like Still's murmur is a common one. It's just the sound of blood moving quickly, maybe a bit turbulently, through perfectly normal heart structures. Often changes when they sit up or lie down.
So the real skill is telling the difference between those normal sounds and something that might indicate, say, a congenital heart defect.
Precisely. Making that distinction, normal development versus early disease, is absolutely critical.
Okay, let's shift to vital signs now, specifically blood pressure. A child's vascular system, their total blood volume, it's all so different. We can't just use adult ranges, right?
Right. And this brings us to a really handy tool from the source material. It's a quick formula to estimate a normal systolic blood pressure range based on the child's age.
Okay, let's break that down. That sounds like something really practical you could use on the spot.
It is. So you take the child's age in years, multiply that number by 2.
Okay, age in years times 2.
Then, to get the low end of the normal systolic range, you add 70 to that result.
Got it. Age times 2 plus 70 for the low end.
And to get the high end of the normal range, you add 90 instead.
Age times 2 plus 90 for the high end. Okay, so let's try an example. A 10-year-old.
Okay, so 10 times 2 is 20.
Right.
Add 70, you get 90. That's your low end.
Right.
Add 90 to the 20, you get 110. That's your high end.
So for a 10-year-old, a normal systolic BP would be roughly between 90 and 110 millimilli Ag. That's really useful for a quick baseline check.
Exactly. It gives you clinical boundaries, a starting point. And you also have to remember children have a much higher metabolic rate than adults.
Okay.
And that higher rate affects everything. It means their vital signs change faster, they can spike a fever much more quickly, and they can lose fluids and get dehydrated way faster than adults.
All right.
All of these things just underscore that you need a completely different mindset, a different lens for pediatric assessment.
So once we kind of get our heads around these physical differences, the next big challenge is actually engaging with the child and their parent or caregiver. Assessing a child isn't just about the patient. It's often a triad, right? The child, the parent, the assessor. And getting a good history really depends on communication, building trust, the soft skills, basically.
Right. Totally foundational. And it starts the second you walk in the room and introduce yourself. You need to clearly explain what you're going to do, not just to the parent, but to the child, too, in language they can understand based on their age. That transparency is step one for building trust.
Yeah, and the source material lists some really practical techniques, things like making sure there's privacy, which is just basic respect, and using open-ended questions, but asking them one at a time. Why is that one at a time part so important?
It just avoids overwhelming them. If you fire off like 3 questions at once, especially to a child or a stressed parent, they often just answer the last thing they heard or they get sidetracked.
Yeah, makes sense.
So slowing down, using simple, clear words, avoiding confusing medical jargon that gets you much better information, and probably the most important thing, which sounds obvious but can get overlooked, honesty.
Honesty about what's going to happen. Like, not saying a shot won't hurt if it probably will.
Exactly that. You acknowledge it might be uncomfortable or hurt a little, but you reassure them. You don't lie. That destroys trust instantly. And beyond just talking, you have to really listen. Pay attention to the tone, the body language of both the child and the parent. And of course, if there's any kind of language barrier, getting a qualified interpreter isn't optional. It's essential for getting an accurate history.
Okay, so let's structure how we gather that information. The source material suggests splitting the history into 2 parts. The quick, urgent stuff, and then the more detailed assessment. What absolutely has to be in that first rapid assessment?
Right. The quick history is all about triage and immediate safety. You need 4 key things. 1, why are they here now? What's the main reason for the visit, the chief complaint? 2, do they have any ongoing chronic medical conditions? 3, what medications do they take regularly? And crucially, when was the last time they took each one? That timing is vital. And 4, any known allergies.
Okay, why is the timing of that last medication dose so much more critical in kids compared to adults?
Well, remember that higher metabolic rate. And they also have higher fluid turnover. It means how their bodies handle drugs absorption, distribution, metabolism, excretion, the whole pharmacokinetic process can be really different and variable.
Oh, okay.
So knowing exactly when they had the last dose helps you figure out if the drug is at its peak effect, if maybe the timing contributed to the problem they're having now, or if they need another dose right away.
Got it. So once you've got that essential safety info, you move on to the more detailed history. This covers the usual bases: chief complaint in more detail, history of present illness, birth history, family history, current health status, review of systems. But the sources really emphasize digging into the psychosocial and developmental data. This seems like where you get a lot of context.
Oh, absolutely. This is where you look beyond the clinic walls into the child's actual life. You're looking for stressors, patterns. You need to ask about daily routines, sleep, diet, regular schedules. Consistency often tells you about stability. You ask about the home environment. Have there been any big changes recently, good or bad? Like a new baby, moving house, parents separating, maybe exposure to conflict or violence. You check on school or daycare, their activity levels. All these details help put symptoms and behaviors into context.
And for older kids, adolescents, the history has to shift into some pretty sensitive areas, but they're essential safety checks.
Definitely. As they get older, you have to screen for things like depression, substance use. You need to ask directly but sensitively about sexual activity. And critically, you must ask about suicidal thoughts or ideation, sometimes just noted as SI.
Right.
These aren't just boxes to tick, they're complex conversations. You need to be aware the young person might be hesitant or scared to talk about this stuff, but often this is where you find the real root cause of vague physical complaints.
And just wrapping up this section on history and context, the sources stress basic safety checks, starting with the immediate environment. What does that look like in practice?
It means literally looking around. In a clinic or hospital setting, are the side rails up on the crib or bed? Are they properly secured? Is the room set up safely? Are they wearing the right ID bands? For infants, sometimes there are special halo bands for specific risks. And involving the parents is also a safety strategy. It keeps a child comfortable, sure, but it also makes the parent an active partner in preventing potential errors or harm while they're in your care.
Okay, we've covered the physical differences, the communication needed. Now let's get into the actual mechanics of the assessment, starting with vital signs. And this is where pediatric practice really does flip the standard adult procedure upside down.
Yeah, in adult care, consistency is key, right? Same order every time. In pediatrics, the key is flexibility, and it's all guided by one main principle. Do the least disturbing thing first to get the most accurate reading. Which brings us to the golden rule. The rule of the sleeping child.
Which is?
Do not wake a sleeping baby unless you absolutely have to.
Right, because as soon as you wake them,
They cry. And crying immediately shoots up their heart rate, their respiratory rate, and boom, your baseline measurements are completely useless.
okay.
So if the baby is sleeping or just quiet and content in the parent's arms, you start with the things that involve the least touching or disruption. Usually that means listening first auscultation. Quiet assessment before disturbing assessment.
So this leads to a very specific order for taking vital signs, moving from least invasive to most invasive. Let's walk through that sequence. Why this order?
Okay, step one, absolutely first. Count respirations. You do this before you touch the child, before you move them. Just watch their chest or abdomen rise and fall. A baby's breathing is shallow and can change instantly with any stimulation.
So you got to get that baseline respiratory rate while they're undisturbed. Okay, step two.
Step two, count the apical heart rate. This means listening with your stethoscope directly on their chest. It's a bit more invasive than just watching them breathe, obviously, but you can often do it without causing too much fuss, especially if they're still calm or sleeping.
Okay, so at this point, we've hopefully captured the two vitals most sensitive to disturbance respiration and heart rate while they're relatively calm.
Exactly. Now you move on to the things more likely to cause upset.
Right.
Step three, measure blood pressure if you need to. Taking a BP can be annoying. The cuff squeezes. It often makes kids fussy or cry.
Okay, so that's third and last.
Step four, measure the temperature last. This is often the most invasive part, especially if you're doing a rectal temp in an infant, which is sometimes considered most accurate. It's the step most likely to trigger a full-on meltdown. So, by saving it for the end, you've already got your reliable baseline respiration and heart rate data safely recorded.
That sequence makes so much sense when you frame it around minimizing disturbance.
Yeah.
Now, beyond those core vital signs, the assessment can include other measurements or monitoring, right? You mentioned plagiocephaly earlier.
Yeah, that's looking at the shape of the baby's head, checking for any flat spots, often from them lying in one position too much. It's part of the physical exam. And then there are more specialized monitoring concerns, especially for babies who might be at higher risk for breathing problems, which brings us back to apnea monitoring.
Right, and defining what actually counts as an apnea event. The source material had a specific definition, didn't it? Often called a BRUE now.
Yes. BRUE, a brief, resolved, unexplained event. It used to be called an ALTE, or apparent life-threatening event, but the terminology shifted to be more descriptive, and the definition is right there in the name. It's brief. The episode doesn't last long. It's resolved. The baby recovers on their own, back to normal. And it's unexplained, meaning even after a thorough checkup, doctors can't find a clear cause like reflux or a seizure.
Got it.
It's that unexplained part that's often the key. It suggests there might be some underlying instability, maybe neurological, that needs careful watching, even though the event itself resolved.
Okay, sequence mastered. Let's move into the actual head-to-toe physical exam, but really focusing on those things that are unique to kids, the landmarks you absolutely have to check.
Right, starting at the top, head and face. In infants, the fontanelles, those soft spots on the scale, are critical. You need to feel them. They should be soft and flat.
And if they're not soft and flat, that's a big deal.
Yep. Huge deal. If a fontanelle feels sunken or depressed, that's a classic sign of dehydration, which is really serious in infants because they lose fluid so fast.
Okay.
On the flip side, if it feels bulging or tense, that suggests increased pressure inside the skull, increased intracranial pressure, or ICP. Also very serious. You also know roughly when they close. The one at the back, the posterior, usually closes by about 2 or 3 months. The big one on top, the anterior, closes later, typically between 12 and 18 months. If they close way too early or stay open way too long, that's also significant.
Good points. Okay, moving to the eyes. We check they're symmetrical, clear, no drainage, and checking if they can follow things.
Yep. Testing their ability to follow an object smoothly tracks those cranial nerves controlling eye movement, the 6 cardinal fields of gaze.
Okay, now ears. Symmetry again, but alignment is also key here.
Yes, you check for symmetry, make sure the skin's intact, no weird drainage. But the alignment is a really important anatomical check. The top of the ear, the helix, should line up roughly horizontally with the outer corner of the eye.
And if they don't, if the ears seem low set.
Low-set ears can sometimes be a marker, a red flag for certain genetic syndromes or developmental issues. It's because the ears develop around the same time in gestation as the kidneys and some other structures. So if the ears look unusual, it prompts a closer look elsewhere too.
Wow, okay, that's exactly the kind of detailed connection we need. What about the nose? We know they're nose breathers, so checking it's clear is vital. But you mentioned a subtle sign of chronic issues.
Yeah, asides making sure the septum is straight and the passages are open, you look closely at the tip of the nose. Sometimes you'll see a little horizontal crease across the bridge.
A crease, what does that mean?
It's often from the kid constantly rubbing their itchy nose upward with their hand. It's called the allergic salute. That crease, maybe along with dark circles under the eyes, those are allergic shiners, from pooled blood flow, can be a telltale sign of chronic allergies like allergic rhinitis. It's an environmental clue you can spot on exam.
Fascinating.
Okay.
Then we move into the mouth. Checking gums, teeth. It's also like a developmental clock, right?
Definitely. Gums should be pink and healthy, not red or swollen. Then the teeth. First ones usually pop through around 6 months. They should have all 20 baby teeth by about age 2, and they start losing those baby teeth around age 6 to make way for adult teeth. Knowing that timeline helps assess nutrition, hygiene, maybe even flags neglect if things are really off. And of course, you need a good look inside for any signs of a cleft lip or cleft palate, which can significantly impact feeding.
Right. So after the head, face, sensory checks, we move down the body, trunk, extremities.
Yeah. Assessing the trunk involves listening to the heart and lungs, checking the abdomen for the GI and GU systems. It's similar to an adult exam, but you're always interpreting the findings based on pediatric norms, remembering those faster heart rates, faster breathing rates we talked about.
Okay.
For the arms and legs, the extremities, you're looking for symmetrical movement, equal strength, equal temperature. Differences side to side could point to neurological issues or problems with circulation.
And then skin and hydration status seem really critical.
Absolutely paramount, especially hydration, given how quickly kids can get dehydrated. You check the skin for any bruises, cuts, wounds, always considering the context and potential need for reporting if something looks suspicious.
Right.
For hydration, you check skin turgor, pinch a bit of skin gently, usually on the abdomen, and see if it snaps right back. If it stays tented, that's a bad sign. You look at their mucous membranes inside the mouth. Are they moist or dry? And check capillary refill time. Press briefly on a fingernail or toenail bed. See how quickly the pink color returns. Should be less than 2 seconds. Delay means poor perfusion, often linked to dehydration.
And finally, the genital and perineal areas need specific assessment too, always ensuring privacy and sensitivity.
Correct. That's a necessary part of a complete exam, done respectfully.
Okay, this feels like a natural shift from just looking at the body's structure to how it functions, especially the nervous system. We're talking about developmental milestones now. For anyone learning about pediatric health, tracking these milestones seems absolutely fundamental.
It really is. Milestones are like windows into how the brain and nervous system are maturing, how that connection between brain and body is developing. So the assessment involves reviewing these milestones, motor, cognitive, language, social, along with checking specific cranial nerves, sensory function, and reflexes.
Like the parachute reflex.
Exactly, but that's a great example. When an infant is tilted forward suddenly, like they're falling, they should automatically fling their arms out forward to catch themselves.
Oh.
Seeing that reflex, which usually appears around 7 months or so, tells you that their balance mechanisms and protective responses are integrating properly.
Got it. And the advice was clear. Don't get bogged down trying to memorize every single date for every milestone right away.
Mm.
It's more about understanding the sequence and the general time windows for these key skills to emerge.
Precisely. Focus on the major ones first. Let's break down fine motor skills, the small, precise movements.
Okay.
It starts early. Just grasping an object placed in their hand happens around 2 to 3 months. Initially, it's more of a reflex grasp. Then a big step is transferring an object from one hand to the other. That shows coordination between the two sides of the brain and body, usually happens around 7 months.
And the one everyone seems to watch for is the pincer grasp, right?
That's the big one for dexterity, using the thumb and forefinger precisely to pick up small things. That typically develops around 10 months.
Huge for self-feeding.
Exactly. Lets them start picking up small pieces of food. Building on that, they can start reparting, removing objects from a container by about 11 months. And a classic benchmark around 12 months is building a tower of 2 blocks. Sounds simple, but it shows visual motor planning and coordination.
Okay, that's fine motor. Now let's look at the growth motor timeline, the big movements leading to mobility.
Right. This starts right from birth. You expect to see some head lag in newborns when you gently pull them up to sit, their head falls back a bit. That's normal for the first couple of months. But by 4 months, they should have good, strong head control, no more lag.
Okay, and rolling over is a big early one too.
Yep, happens in stages. Usually they roll from their tummy onto their back first, around 5 to 6 months. Then rolling both ways, tummy to back, A and D back to tummy, is typical by about 7 months. That integration is a key neurological step. Sitting up by themselves without any support, that usually happens by 8 months. Shows good trunk stability.
And things seem to move quickly towards walking after that point.
They do. Getting from lying prone up into a sitting position happens around 10 months. That takes quite a bit of coordination and strength. And then the moment everyone waits for, walking, typically achieved somewhere around 15 months, although there's definitely a normal range around that.
So when assessing these, it's not just about hitting the exact date.
No, it's about the progression. And critically, you're watching for any loss of skills. If a child could do something and now they can't, developmental regression, that is a major red flag and needs immediate investigation for neurological problems.
Okay, moving from typical development, we need to talk about the warning signs. Those behaviors, often subtle, that might signal a potential cognitive impairment and need a closer look.
Right. These aren't always physical findings. They're often about interaction or lack thereof in basic functions. The list includes things like the child just doesn't respond much to touch or your voice or movement around them. That could indicate sensory or processing issues. Or persistent irritability crying that's really hard to soothe, way beyond normal fussiness. Poor or really slow feeding is another one. A healthy feed for an infant might take 20-30 minutes. If it consistently takes much, much longer or they're just not interested, that's a concern.
Okay.
Also, poor eye contact during feeding. That interaction is so important for bonding and communication. A consistent lack of it can be a sign. And lastly, just diminished spontaneous activity. The child seems unusually quiet, maybe lethargic, not exploring or moving much when you'd expect them to.
Understanding what could cause cognitive impairment seems important too. The risks seem to span the entire period before, during, and after birth. Let's break down those prenatal and perinatal factors, first things happening during pregnancy or delivery.
Sure. These are events that can directly impact brain development. Things like infections the mother might get during pregnancy, or exposure to toxins or drugs, intrauterine infection and intoxication. Trauma is another big category. Injuries before birth, complications during a difficult birth, perinatal trauma, or significant head injuries after birth, postnatal.
Okay. Then there are internal factors, issues within the child's own system, maybe genetic or metabolic.
Exactly. This includes things like metabolic or endocrine disorders where the body can't process nutrients or hormones correctly. Inadequate nutrition itself, especially during critical brain growth periods. Brain diseases that occur after birth, like severe meningitis or encephalitis, and known chromosomal anomalies, like Down syndrome, which have inherent effects on neurological development.
And finally, there are external or timing factors, things related to the environment or when the baby was born.
Right. The timing of birth itself matters. Being born too early, prematurity, having a very low birth weight, or even being born significantly post-term can increase neurological risks. Environmental exposures are critical to assess, with lead exposure being a major known neurotoxin we need to screen for. Then there are sometimes unknown prenatal influences we can't pin down, and also psychiatric disorders that start in childhood and can affect development.
Wow, that's a huge range of potential causes,
Yeah.
which really highlights why prevention is so crucial. What are some of those primary prevention strategies the sources mention?
Prevention starts broad with public health measures, like rubella immunization for everyone, because rubella during pregnancy can cause severe birth defects, offering genetic counseling to families who have known risk factors. And a lot of it comes down to maternal counseling during pregnancy, emphasizing folic acid supplements to help prevent neural tube defects, educating about the dangers of alcohol to prevent fetal alcohol syndrome, teaching how to avoid lead exposure,
Right.
and finally, providing really good specialized support and early intervention for babies born preterm or with other high-risk factors can make a huge difference in optimizing their neurological outcomes.
Let's focus now on a specific area within neurodevelopment that gets a lot of attention. Autism spectrum disorders, or ASDs. The source material describes these as complex neurodevelopmental disorders affecting brain function. And that word spectrum is key, right? It covers a huge range.
Absolutely vital to understand. It means ASD presents very differently from person to person. The range goes from mild challenges to severe impairments. Historically, you might hear about different labels like autistic disorder, Asperger syndrome, or PDD-NAS. Modern criteria, like in the DSM-5, have streamlined this a bit, but the concept of a spectrum remains. And across that spectrum, you often see certain core features, like repetitive behaviors and a strong need for routine and predictability.
And the source mentioned that need for routine comes from a place of anxiety,
Yeah.
because routine is known, not unknown.
Exactly. Structure provides a sense of safety and predictability in a world that can feel overwhelming or confusing.
Okay, so how is ASD actually diagnosed? It relies on specific criteria, observed behaviors.
Yes, formal diagnosis uses standardized criteria like those outlined in diagnostic manuals such as a DSM. The key is looking for patterns of behavior that usually need to be present before the age of 3. Diagnosis generally requires significant challenges in 3 main areas. First, social interaction. Difficulty with back and forth conversation, maybe showing little interest in peers, trouble understanding social cues like facial expressions or body language.
Okay, social interaction. What's the second area?
Second, communication. This can range from delays in learning to speak at all to difficulty initiating or sustaining conversations or maybe using language in repetitive or unusual ways.
Got it. And the third?
Third, restricted repetitive patterns of behavior, interests, or activities. This could be things like repetitive body movements, rocking, hand flapping, or an intense, narrow focus on specific topics or parts of objects, or distress at small changes in routine.
So, to catch potential ASD early, there are screening tools used in regular pediatric checkups.
Yes, early screening is crucial. The MCHET-R, that's the Modified Checklist for Autism in Toddlers, revised, is mentioned as a standard evidence-based questionnaire. Parents fill it out, usually around 18-24 months. It helps flag children who might need a more in-depth evaluation by specialists to see if they meet the criteria for ASD.
Okay, and if a child is diagnosed, what about treatment or intervention? There's
Yeah.
no cure, right? So what's the focus?
Right, no cure. The focus is entirely on support and maximizing function. The most promising approaches involve intensive behavioral therapies. Applied behavior analysis, or ABA, is a well-known one. And building those highly structured routines we talked about is fundamental. Consistency really helps. But it's really important to note, the source stresses this. How well a child responds to interventions varies hugely. There's no one-size-fits-all approach. Programs need to be tailored and flexible.
And the impact on the family. The source described ASD as potentially becoming a family disease. That sounds intense.
It is. The demands, emotional, financial, logistical, can be immense for the whole family. So, supporting the family unit is just as important as supporting the child. A big part of that is helping parents work through feelings of guilt or shame, which are common but totally unwarranted. Family counseling can be incredibly helpful. Connecting families with support networks is also key. Organizations like the Autism Society of America, ASA, provide invaluable resources, community, and advocacy. Our role as healthcare supporters evolves too. Initially, it's about helping families navigate therapies and support services for the child at home and school. Later on, it might involve assisting with planning for long-term care and support as the individual transitions into adulthood. Tag outro, synthesis, and final thought.
Wow, okay. We have covered a lot of ground today, really diving deep into this pediatric assessment roadmap. From understanding that fundamental difference in the infant airway, the obligate nose breathing, to having that practical tool, the age by 2 plus 70/90 formula for blood pressure, those are some really concrete takeaways.
Yeah, and I think understanding why the vital sign sequence is flipped, starting quiet, ending noisy, really sticks, prioritizing respiration first, temperature last, and seeing how quickly those developmental milestones unfold, grasping at 2 months, walking around 15 months, it really drives home that this whole assessment process is dynamic. You're constantly connecting these different pieces, anatomy, physiology, development.
Absolutely. Connecting back to your goal, listener, of getting this knowledge quickly but thoroughly, it's about seeing the child not as static, but as this rapidly changing system.
It truly is. Which brings us to a final thought, something to maybe chew on a bit, building on those subtle signs we discussed. We talked about the definition of a BRUE, that apnea event being brief, resolved, and unexplained. That definition focuses our attention on something temporary, something that went away on its own, but might still signal an underlying issue because we couldn't easily explain it. So, thinking about how vital early detection is for developmental or cognitive differences, how can we apply that same thinking, looking for the brief, resolved, but maybe unexplained signs to behavioral observations?
Ah, okay. Like those early behavioral cues we listed.
Exactly. Things like that unusual irritability, or the slow feeding, or the poor eye contact, or diminished activity. If those things happen sometimes, seem to resolve, but don't have an obvious immediate cause, could those be part of an early warning score? Could those transient, subtle behavioral flags be the critical signal that specialized intervention is needed before a bigger problem becomes
That's
obvious?
a really interesting question. Looking for the subtle temporary changes as potential early warnings, not just waiting for the big persistent problems.
Precisely. Sometimes the key to long-term health is catching and acting on those fleeting signs that something isn't quite right, even if it seems to resolve on its own in the moment. It's about recognizing those patterns early.